This training module is a practical demonstration on the use of acute peritoneal dialysis in children with life-threatening acute kidney injury. The types of situations we envisage that it may be required is where the children are anuric following severe sepsis, such as with malaria, leptospirosis, severe dehydration following gastroenteritis, acute hemolytic uremic syndrome, severe intractable diabetic ketoacidosis or snakebite. The aim is to provide 1 week of dialysis so the kidney injury sustained as part of the underlying condition has a chance to recover and to allow the children to go from being in the anuric situation to a period where they will start to pass urine spontaneously. The clinical indication for dialysis is acute pulmonary edema or life-threatening hypokalemia. So if you have a child in this situation, the first thing we need to do is to prepare the patient. The child needs to be sedated. If the child's in pulmonary edema, oxygen will be required to ensure that the child is not hypoxic. There will need to be somebody at the head of the bed to supervise the child's breathing and well-being at all times. If you have an oxygen saturation monitor or an ECG, particularly if the child has life-threatening hypokalemia, it's very important that the child be monitored. If these are not available, certainly someone at the head of the bed to assess the colour and the breathing pattern of the child while you're inserting the catheter under sedation is extremely important. Prior to commencing dialysis, we will first check the child's blood pressure, whatever scales you have available to make sure that the child is appropriately weighed so you have an indication of their fluid status prior to dialysis. It's very important that we sedate the child. The types of sedation would depend on what is available locally and what is your preferred option. The types of things that we use are midazolam and ketamine, or midazolam and oral morphine, or in some situations chloral hydrate may be a preferred option. It's most likely that the child will already have an intravenous line inserted, and this can be used to give prophylactic antibiotics prior to the insertion of the catheter to decrease the risk of infection. The antibiotics that we will provide are cefazolin at a dose of 20 mg per kilogram and gentamicin at a stat dose of 2.5 mg per kilogram. The maximum dose that is required is 1 gram for cefazolin and 80 milligrams for gentamicin as a stat dose. Before insertion of the peritoneal dialysis catheter, it's very important to make sure that the bladder is completely empty with the insertion of a bladder catheter, either as an acute in-out catheter or attached to a drain bag. This will ensure that the child's bladder is completely empty and there is no risk of introducing the catheter into the bladder at the time of insertion.
I'm going to go through setting up the peritoneal dialysis set. It's very important that the setup is done in a very clean area that's not crowded and there is no dust around, because infection is a major complication of peritoneal dialysis, leading to sepsis and treatment failure. So the most important thing is to prevent infection and be very clean and follow an aseptic technique strictly when you're setting up the equipment. I'll start by going through the equipment that's in the pack that will be provided for dialysis. Starting off with the peritoneal dialysis set, which must be undamaged, so you should check the package that it hasn't been accidentally opened and there aren't any holes or damage to the package. We're going to need some clean clamps, which will also be provided, 2 needles, 2 syringes, some alcoholic wipes, because we're going to add some heparin to the fluid, a vial of heparin, some sterile gloves, a scrub brush, a sterile drape for a dressing trolley. Then we have some dialysis solution, There are 3 different strengths of dialysis solution depending on how much fluid the child is going to need to be removed. So the fluid's colour coded and also labelled. We start with 1.5, which is a yellow indicator, and 1.5 is the weaker strength of glucose, so less fluid will be removed when we use the 1.5. We have 2.3% glucose, which is green, so a moderate amount of fluid will be removed with the 2.3%. Then we have 4.25% glucose, which is coloured red, and we won't actually use that initially. That's only to be used if the child's very fluid overloaded and we're not achieving adequate fluid removal. We have a sterile drain bag which will be used to collect the ultrafiltration fluid. A gown for the person that's setting up the equipment. Some disinfectant for cleaning the dressing trolley and the equipment that we're going to use for the dialysis. We will need a peritoneal dialysis chart with orders on it, and you'll continue to use that to record the fluid that's going into the child and the return and the ultrafiltration balance. And then we need somewhere to put the drain bag so that we don't have dust or bacteria backtracking into the circuit. So that can either be a clean plastic bag, a towel, or a container of some kind that's been cleaned prior to setting up your equipment. We'll also need a clean trolley or a clean table, something that can be cleaned with antiseptic to set up our sterile equipment, and a pole to hang the dialysis fluid and the dialysis set, and in addition some tape, because we'll need to tape the burettes to the pole. Now I'm going to set up the equipment. Staff involved in setting up the peritoneal dialysis equipment should be following an aseptic technique, which includes hand washing. Okay, so I'm going to perform a simple hand wash just to clean my area and get my equipment organised. And can I just say that drying hands is just as important as washing hands, because if you leave your hands moist, bacteria can grow in the moist areas. That can be transferred to your equipment. So any solution can be used, detergent solution, anything you use to clean the environment in the hospital can be used to clean the area that you're going to open your dialysis equipment. I'm going to clean my trolley with cleaning solution and my pole, because I'm going to be hanging the dialysis solution there. I'm going to start setting up the dialysis set now. I will have an assistant. The assistant should wash their hands as well. They won't actually be touching the aseptic area, but they will be handing things to me and hanging my bags up when I require that to happen. So just a hand wash, and then to have some antiseptic hand rub available for extra hygiene to complement the hand washing, and that will be available in the dialysis packs. I'm going to now wash my hands for 1 minute from fingertips to elbows, and remembering the webs of my fingers, and pay particular attention to the fingernail. Setting up the equipment, I have a sterile drape to cover my trolley. Just touching the corners and holding the drape away from my clothing, and to cover the trolley. I'll start by peeling open the peritoneal dialysis packet, making sure not to touch it. for the heparin. Needles for the heparin. I'm going to start the peritoneal dialysis using one bag of 1.5% glucose and one bag of 2.3% glucose. I'll drop them onto the sterile field. One on top of the other. I'm also going to use a large drain bag. I'll open up a gown and some gloves, which I'll be wearing after I've done my 3-minute hand wash. I have 2 alcohol wipes, which I'll get my assistant to peel open, and I'll take them once I'm scrubbed. And I also have some clean clamps, which I'll need at a later stage. They've been cleaned with antiseptic as well. I'm going to start by organising my equipment, and I have to prepare the bag because the bag is sealed down the middle. So 2 compartments. One with the glucose and one with the electrolytes. So I need to break that seal. That can be done by pulling it apart or rolling it. I prefer to roll it from the corner, and the pressure will burst the seal. Keep rolling and just gently turn the bag to mix the solutions together. Now I'm going to add heparin to the bags, because sometimes when you first insert a dialysis catheter, you have fibrin formation which can block off the catheter. So we will be adding 500 units per litre of dialysis solution. So that will be 1 ml of 1000 unit per ml heparin to each 2 litre bag of dialysis solution. To do that, I'm going to first of all wrap the injection port. So the blue port is the injection port. I'm going to wrap the injection port with an alcohol wipe. Then I'll draw up my heparin and I will add it. Okay, so just wrapping the port and repeating that with the other bag. And it's heparin 1000 units per ml. And using a clean syringe and needle for each bag, just in case you contaminate the needle. Very important to prevent infection. So I'm going to add 1 ml to the 2 litre 2.3 bag. Just draw back and inject quite quickly a couple of times just to clear the port, because it's quite a large injection port and the heparin could perhaps get stuck in the port and not go into the fluid. And repeating with the second bag. So 1 ml of heparin into the 1.5 5% solution. Once again, draw back, clearing the port. I'm now going to prepare my set, and I am going to change my gloves, just in case I've touched anything or contaminated them. Okay, I'm just going to organise my set. So I have a drain bag which has got 2 large drain bags on. So clamping it off, clamp each end off so that I'm not going to lose effluent onto the floor, and then that will go to the dialysis set. This is my peritoneal dialysis giving set, so which consists of an administration set with 2 ports to go to 2 bags. So I'm going to hang a 1.5% bag and a 2.3% to start with. So red means filling the patient, and then there's a blue clamp which is the drain clamp. So I'll actually clamp those off for now. And there's a blue roller clamp here, which I'll also roll down till I'm ready to prime the set. So that's the fill chamber. It's measured in increments up to 250 mils, and it has a little ball there which will stop the solution to prevent air going into patients if this becomes empty. Okay. So what I might do, just to make things easier, it's a little bit complicated, I'll hang the bags onto the IV pole. So I just need to unravel this tubing. So I'm going to hang that to my assistant, where we can possibly contaminate, so just be very careful. I'm going to attach it. I'll close that clamp first. I'm going to attach it to this giving set. So removing the white cap, just drop it onto the clean surface, take off the yellow cap, and it's a lure lock, so we just tighten it into position. So make sure that that is twisted so that it's tight and won't pull apart. Connect the second giving set to the green port. So clamping, taking off the white cap, taking off the green cap, connecting the 2 together, twisting until it's tight, and just make sure that it's not going to pull apart. I'll unravel this tubing and hand the bags to my assistant. I'll hang that over the pole without touching. It's important when you're hanging the bags to make sure that the piece of tubing that goes to the patient doesn't hit the floor. So just make sure that you're hanging on to that at all times. So I'm now going to connect my drainage cylinder, which is also measured up to 240 mils. I'm going to connect it to the large drain bags. So cap off that end, cap off that end, twist the 2 together, and clamp that clamp between the large bags and the drainage cylinder. This end is going to go to the patient. Red indicates filling the patient. Blue indicates effluent flowing out of the patient. So that must be kept clean at all times. Now, my assistant is going to hand me the container that I'm going to put the drain bags into to keep them clean and off the floor. I'll just drop them into there without touching. And my assistant will tape the drain cylinder onto the pole at a low level. And I need to secure that end so that it doesn't fall off. So keeping an eye on that. I'm going to fill this cylinder, the fill cylinder, with 1.5% fluid to start with. So to do that, make sure I've got the 1.5% bag. I'm going to prime initially the air from the fluid bag into this empty bag up here, and then my assistant will clamp that bag. So to run the air from this bag into that drain, empty bag, I'm going to turn the dial to number 2. Just tapping the air out so that there's no possibility of running air accidentally into the patient. Once all the little bubbles can no longer be seen, my assistant will put a clamp on. I need to prime the 2.3 bag the same way as I primed the 1.5 from the bag into the drainage, just to clear the air. Now I'm going to fill the burette, making sure that the roller clamp at the bottom is closed. I open the clamp, the red clamp, and I turn the dial to number 3, and it will fill. It's full now, so clamp the red clamp. And leave that pointer on the dial on number 3, and it should stay there for the duration of the dialysis. I now need to remove the air out of the tubing that goes to the patient, and also out of the tubing that will be going to the drainage burette. So to do that, I need to make sure that the chamber is full of fluid. So to do that, I will squeeze it twice or 3 times until the ball valve is released and sits at the top of the fluid. Then I will release my roller clamp and release the blue clamp. Release the red clamp. So just release that just a little, and then tighten it. Yeah, that's where I need the clamp. At the bottom, until I've primed the air into the drainage chamber, drainage burette. And once I'm sure I've clear of air, clamp the blue clamp. And then my assistant can take just for the minute, and I'll just clear the end, tighten it again, and it's ready to connect to the patient.
So here we have an illustration of a standard sterile pack, which will be used for the purposes of cleaning, povidone iodine or betadine solution and some gauze swabs, local anesthetic, lignocaine, in the dose of up to 3 milligrams per kilogram. We will then be using our knife to make an incision. It's an 11 blade which has a sharp pointed tip, together with our syringe and needle and our guide wire and dilating trocar and the Tenkoff catheter, which will be present in your packs with a single Teflon cuff. A pair of sterile gloves, essential, and some minor or some basic surgical instruments, including a mosquito forceps, toothed adson, and suture material, non-absorbable monofilament. So here we have an anatomical demonstration of a child's anterior abdominal wall with the umbilicus and the medial borders of the rectus abdominis marked out. The child's feet are inferiorly and the child's head superiorly in the image as you see it. Our point of attention is the inferior aspect of the umbilicus in the midline between the two rectus abdominis muscles. There is a groove, which is the conjoined sheath, or anatomically the linea alba. The procedure begins with preparing and draping the area. So we use a povidone iodine soaked swab, and the cleaning technique is concentric circles, spreading from the point that you need maximally cleaned, in other words, the point of insertion. The technique is not to return to the site in the center of the concentric ring, but merely to discard the swab with a new swab, start at the point of maximal cleanliness, and again constructing concentric rings away from the site that needs to be the most sterile. Once that's been performed, we then put our fenestrated drape over the area of interest and introduce our local anesthetic. Here we can see the depiction of the umbilicus, the rectus abdominal muscle on either side, and inferior to the umbilicus we are going to insert our local anesthetic. Local anesthetic can either be Marcaine or lignocaine. In this instance it's lignocaine at a dose which is less than 3 milligrams per kilogram. It is introduced widely into the area, creating a subcutaneous bleb, aspirating before injecting in each of the positions involved. In children, it's often helpful to only have one insertion site of your needle and simply to fan out the injection across the intended incision line. Once sufficient local anesthetic has gone in, you can then return your syringe to its sheath and plan the surgical incision. Again, being aware of where the umbilicus is and the two rectus abdominis sheath, we perform a vertical incision in the midline, about 1 centimeter inferior to the umbilicus. Using the 11 blade, which is the sharp pointed blade, we perform a stabbing incision. So it is a puncture in and then drawing the blade across the skin to create an incision that is of sufficient length to accommodate the sheath, both our catheter and also in this instance its first cuff, the cuff closest to the fenestrations in the distal extent of the catheter. Then we perform a gentle blunt dissection heading posteriorly. At this stage there might be a little bit of blood. If you've got some adrenaline mixed with your local anesthetic, that is helpful in a concentration of 1 in 200,000. This will prevent any cutaneous or minimize the cutaneous bleeding. This dissection is simply blunt and it's through the fat, which offers very little resistance, down to a much more resistant structure, the linea alba, or the midline sheath of the abdomen. Once this point has been reached, the blunt dissection is stopped. This is the needle and the syringe that you'll be getting in the packs. It's a fairly standard insertion needle that is wide enough to accept the guide wire through the center of it. Now the insertion technique is to introduce the needle into the wound that you've created, allow the needle tip to bounce on the fascia of the linea alba, and then aim the needle inferiorly towards the coccyx. Imagine where the child's coccyx is, point the needle towards the coccyx. The reason for that is to create an oblique tunnel through the midline sheath. This will facilitate the placement and prolonged positioning of the catheter tubing. If the insertion is in a vertical position, the catheter may easily migrate out of the pelvis. So with the needle pointing towards the coccyx, we then go through our previously blunt dissected wound in the fat, allow the needle to tap down and feel the resistance of the sheath, and then with a finger advance down the needle shaft, we prevent the needle from plunging inadvertently into the abdominal cavity, and we apply gentle pressure, as stated previously, towards the coccyx. Once we feel you can see the resistance in the tissues. That's the needle dragging down the fascia as it tries to puncture it, and there may or may not be a sudden give in the tissues as the needle traverses the sheath. Once the needle has traversed the sheath, or one feels like it's traversed the sheath, there are a number of techniques at confirming its insertion. The first important thing is to make sure that there is no blood, air, or bowel content by aspirating gently on the syringe. By gently aspirating on the hub, provided the hub is securely applied to the syringe, and you can see my left hand secures the syringe. So with my left hand securing the hub of the needle, I then aspirate gently on the hub of the needle. If I see air, as in this case, or bowel or blood, my needle tip is in the wrong position and requires repositioning. Sometimes air can leak in between the hub of the needle and the syringe, so you might find small little air leak. If that is the case, resecure the syringe and try again. If there is a significant amount of air, particularly with particulate matter in it or a little bit of bile staining, definitely you're in the wrong position. You're probably in small bowel and you need to reposition the needle. That repositioning includes a complete withdrawal of the needle and reinsertion. The other thing you've got to look out for is bile, which would look like a green or yellowy staining of the fluid. And then clearly you all know what blood looks like, and if that is the case, one pulls back on the needle and repositioned, and the syringe flushed. Having excluded air, blood, or bile, enteric contents, usually demonstrated by particulate fluid or bilious fluid, then one can use a trick to see if the column of fluid you're injecting into the hub of the needle continues to move down the hub of the needle, suggesting that you're in a potential space, as demonstrated there. Once your needle is in the correct position and securing it firmly with one's left hand, we introduce the guide wire. The purpose of the purple straightener is to straighten the shepherd's crook that is a design of the guide wire to prevent visceral perforation. So this is the position that I have the guide wire. The shepherd's crook is straightened, the guide wire being held in my right hand. I then ease back on the guide wire, place the straightener into the hub of the needle, and advance the guide wire. By pinching, pushing, releasing, pulling back on the plastic casing of the guide wire, pinching it again, and advancing it. Remember the needle position, it's facing inferiorly towards the coccyx, hoping that you can direct the guide wire into the pelvis, behind the bladder, and or behind the vagina in females. So where one really wants to be is in the pouch of Douglas, either between the bladder and the rectum, or between the vagina and the rectum in females. The guide wire is advanced. If the guide wire does not pass easily through the tip of the needle, The needle is possibly in the wrong position and needs to be realigned. In this case, the guide wire moves easily. The plastic casing is removed from the back of the guide wire, and the needle and straightener are extracted with gentle pressure by the index finger or a gauze swab on the insertion site. Once the needle has been retracted sufficiently, grasp the guide wire so you don't pull it out during removal of the needle. Trocar and peel away sheath is then applied to the back of the guide wire. It's important at this point to notice the distance from the tip of the radial dilator to the origin of the sheath, and it's important that this entire part of the catheter plus some of the peel away sheath is well inserted into the peritoneal cavity along the line of the guide wire towards the tip of the coccyx. With a finger placed down the shaft of the dilating sheath and with this securely locked in place as it is able to separate, must be securely locked in place, a finger down, gentle circular dilating manner. The radial dilator is then unlocked, and together with the guide wire removed. Radial dilator is then split, and the Tenkoff catheter obviously has two ends and a single cuff. The end with the small holes in it is the end that goes into the peritoneal cavity, as opposed to the end which has no holes in it and traditionally is further from the tip to the cuff. Gentle insertion of the Tenkoff should go easily into the hub. Once it's in position, the peel away sheath is split by applying right angle traction to the tubing. Catheter then advanced further and similar traction applied. If there are two of you, one can apply gentle pressure of the catheter inferiorly and posteriorly while the other splits the sheath. If there is one person, as in this case, it is just a sequential insertion and splitting. Be careful not when the last bit of this catheter splits, it can completely extract both the peel away sheath and the catheter. So guard one's hands when pulling the catheter apart. With that, the catheter is well inserted, the cuff pushed snugly up against the skin, and using a monofilament suture, something inexpensive like a nylon, a deep, broad purse string suture created. And by purse string, I mean a circular suture, which will act both as a securing mechanism as well as a circumferential cerclage in order to create more of a watertight seal. It's important at this point to know that the catheter traverses inferiorly and not to puncture the catheter on your passage through the subcutaneous fat. So nice wide stitch deeply into the fat without puncturing the catheter on your way across the anterior inferior surface. So essentially this purse string looks like a box stitch. The trick with this box stitch is not to make it too tight that it causes necrosis of the skin and subcutaneous tissue around the catheter, but is sufficiently snug to add to its watertight seal. Catheter is inserted into the correct position. And the purse string suture snugged down. If one gets significant blanching of this tissue within the circumference of the suture, it is probably too tight and should be released slightly. Again, you're trying to create a watertight apposition, not strangulation of the tissues. All monofilament sutures should be have at least 6 knots thrown in them. And then the next stage in our assembly is the catheter adapter connection. This catheter adapter comes in 2 parts, and they are screwed together. So we will need to unscrew the distal end of this catheter adapter. It has a metal tubing on the one side and a bullet-shaped cap on the other. There is a small white silastic tubing which comes in the cap, and care should be taken not to lose this during the assembly. This cap, with its tip facing towards the inserted end, should be placed down the tubing. Again, careful not to displace or lose that white tubing from inside it. Notice the tip is facing the patient. The tubing is there. Then the metal tubing is placed down the silastic tubing. Care should be taken not to create tears. It is very easy to buckle the silastic tubing over the metal tip. Push it in all the way up to the hub, demonstrated there, and the plastic tubing goes up a little bit higher, and the outer casing screwed back into position. This will secure the white silastic tubing onto the metal inner tubing in a very secure fashion. So once the adapter is securely in position, the entire catheter is gently flushed with 10 mL of normal saline. Once it's been flushed, a pre-primed adapter is then connected and the system attached to the administration set in a sterile fashion. A test run is then performed to ensure that fluid runs freely into the peritoneal cavity and also drains freely from the pelvis.
Once the catheter has been inserted, we need to apply a dressing. We will apply a sealed dressing, so we're going to envelope it within 2 transparent sterile dressings so that the catheter is sealed and air and water tight. We're going to use Tegaderm, and the equipment that we require for the dressing are two small Tegaderm dressings and then a larger one. The skin and the excess site have already been cleaned with betadine prior to catheter insertion. Just put a sterile towel underneath the catheter, keep it clean. Then I'll clean once more from the exit site underneath and up the catheter. One on the top. Then we need to let the betadine dry off for about 2 minutes for the solution to be effective. Make sure that the skin is really, really dry, otherwise the catheter dressing won't stick. So I'm just going to dry it off. So that's nice and dry. I'm going to envelope the catheter between 2 sterile Tegaderm dressings. So to do that, I fold one in half, like so, and then I'm going to peel back the backing so that the sticky surface will be placed onto the skin underneath the catheter, like so. Make sure that it's stuck. Then the second small Tegaderm dressing will be placed flat over the top. So to do that, to make it seal, I'll remove the backing from the dressing that's already on the skin. And apply the second Tegaderm dressing after removing the backing. over the first dressing. Like that. Then I'll remove the backing. So that catheter is sealed now, and to secure it, I'm going to curl the catheter around and place the large dressing over the top. And that protects the exit site from traction and damage to the exit site, as well as sealing the dressing so that if you pull on the catheter it doesn't pull at the exit site. The dressing should be left in place until the catheter is removed at the end of the week, the full week, unless the catheter is oozing around the exit site, and then you'll need to take the dressing off, clean the skin with povidone iodine, dry it, and apply another dressing as we've done.
Now that the catheter is inserted, it's now and primed with normal saline. We need to connect the Tinkoff catheter to the administration set. It's a matter of removing the distal end of the administration set, removing the protective povidone iodine cap on the catheter, and then screwing it in a clockwise position so that it's nice and tight. It's very important to secure that there is no leak or gap between the catheter and the administration set. Now, once that's secured, please note that there is a pin in the side of the lumen of the administration set. That pin must not be depressed. That's only at disconnection. If the pin is depressed, then it will block the fluid pathway and we won't be able to administer dialysis fluid into the patient. So it's very important that that pin is not depressed until the treatment is completed. We've got our two lines. The red line is for fluid in and the blue line is for fluid out, which is your effluent and hopefully the ultrafiltration. So with our burette, we have the fluid that's filled with the burette, the fluid which is into the patient. We now work out the dose to be administered, and that is 10 millilitres per kilogram of body weight. We can open the red clamp and the patient line, and we watch carefully on the burette to make sure that we only administer the agreed dose to the patient. You can see that the rate of flow will depend upon the height of the burette, so that by heightening the IV pole or lowering it will depend upon the flow of the fluid into the patient. Once the fluid is administered, in this demonstration I've put in 40 mils of fluid. We then clamp the patient line and then would leave the fluid in the peritoneal cavity for a period of an hour. We'll aim to do hourly exchanges. This is while osmosis and diffusion takes place across the peritoneal membrane, and then at the completion of that we can undo the clamp on the patient line, undo the administration set and drain out into the burette, which is down by gravity lower than the abdomen, and that's clamped so that we'll get an accurate record of the fluid that has come out after our administration of the dialysis fluid. This will be charted, and that will be with your peritoneal dialysis acute dialysis kit, so that you can accurately record the volume in and the volume out. The administration set can remain on the patient for the duration of the treatment, changed if they have peritonitis. Since this was put together under aseptic control, it can remain on the patient unless there's a contamination of the circuit. A common but very preventable complication of peritoneal dialysis is peritonitis. Peritonitis is manifested by organisms, microorganisms, getting inside the peritoneal cavity, and then the symptoms are abdominal pain, rigidity, fever, diarrhea, nausea, vomiting, but the most obvious sign is turbid fluid, as seen here in the outflow in the burette. Now, peritonitis is preventable. It certainly lowers the risk by giving the perioperative antibiotics of cefazolin and gentamicin. However, in the unlikely event that the patient does have peritonitis, then intraperitoneal antibiotics are to be administered. In the first instance, we need to sample the peritoneal fluid, and if microbiology facilities are available, a gram stain is done on the fluid. The common organisms are gram-positive cocci or gram-negative rods, and they are your skin commensals, staph, or gram-negatives, E. coli, Pseudomonas, etc. And these two antibiotics will treat most cases of peritonitis. Prior to sampling the turbid fluid, to send for hopefully gram stain and cell count, we do a 1-minute hand wash, and to open up the necessary packs, to place an alcohol swab on the sampling port. To sample the fluid, we need to use a 20 ml syringe and a large bore needle, and we need to send that off to the laboratory using a no-touch technique. To sample the port, since we're sampling a body fluid, it is advisable and mandatory rather to wear gloves. We need a 20 ml syringe. Using an aseptic technique, a large bore needle, having swabbed the top of the burette, the sampling port, we can now invert the burette, and we'll take out a 20 ml sample of fluid. Once you've sampled the effluent, it gets placed into a sterile container using a no-touch technique, and that's then sent to the laboratory, if possible, for a gram stain, so that they can identify the organism. If not, sent for a white cell count, and in any white cell count of greater than 100 is indicative of infection.
Once we've established that the patient has peritonitis and we've collected the sample of dialysis fluid, we need to disconnect the patient from the set using an aseptic technique and set up a new set of dialysis fluid and peritoneal dialysis set completely from scratch, just as we did at the beginning of the video. Once that's set up, we're then going to add the medications that we need to treat peritonitis. That will be heparin, 500 units per litre of peritoneal dialysis fluid, and that will go into the bags when you set the setup. We also need lignocaine, 1%, 1 ml per litre of peritoneal fluid, and that will go into the bag when we set the setup. To the patient, we need to add 0.6 milligrams of gentamicin per kilogram of body weight with a maximum dose of 80 milligrams, and cefazolin 15 milligrams per kilogram of body weight with a maximum dose of 1 gram. And that will be added to the burette of the peritoneal dialysis set. So that will go in, the antibiotics go into the burette, into the inflow burette. The lignocaine and the heparin will be added to the injection port of the dialysis fluid bags. They're 2 litre bags, so it will be 2 mils of lignocaine and 1 mil of heparin, 1,000 units per mil, into each bag. Before adding it, you would wrap the injection port with an alcohol wipe, like so. Would be wrapped around before adding the medication. Anything you add to the peritoneal dialysis fluid potentially is an infection risk. So every time you inject or put a needle into the port, you risk contamination. So you have to be very, very careful about aseptic technique when putting additives into the fluid. Now I'm going to show you how to add the antibiotics to the burette. The equipment that we need is a dressing pack, a pair of sterile gloves, cefazolin, some water for injection for mixing it, some normal saline to reconstitute it, a vial of gentamicin, needles and syringes of appropriate sizes. So generally we use a 10 ml syringe to make up the cefazolin, and depending on your dose of gentamicin, if it's a very small child you will need a 1 ml syringe to get the accurate dose, or a 2 ml syringe. And some alcohol wipes for covering the port of the burette. I'm now going to wash my hands for a minute before setting up the dialysis pack. To open up the dressing pack, and it's just simply a sterile area to have my equipment. So just using the corners, not touching in the centre of the sterile field. Open up my equipment. Don't actually need any of that. I'm really just using the towel underneath. My syringe for my cefazolin and needles. Syringe for my gentamicin. And I'm going to open up a drawing up needle and an injecting needle for each medication, so for each syringe. So I've got 2 drawing up needles and 2 sharp needles for injecting. I'm just going to flip the lid of the cephalothin and cover it with an alcohol wipe. And that just prevents dust or droplet bacteria from settling on the rubber cap while I'm washing my hands. And I'll twist off the gentamicin cap, and I'll just put it so that it's just sitting on the edge of my sterile field. And I'll do the same with the water and the saline, so that I can do this by myself if I haven't got an assistant. I'll use the gauze to hold the vials, or you can have an assistant to help. and I've got my sterile gloves. Then I'll open up my alcohol wipe and cover the injection port of the burette and wrap that so that it's completely covered and protected from the air and droplet bacteria while I'm washing my hands. I'm now going to wash my hands for 3 minutes and don some sterile gloves. I've made the cefazolin up to 10 mils, and I'm going to add 500 milligrams to this patient. That's the dose that I've worked out. So I have 100 milligrams per mil, which is 5 mils, 500 milligrams. And I'm going to now draw up my gentamicin. At a dose of 0.6 milligrams per kilogram. And then for each syringe, I'll change to a sharp needle. I'm going to add the medication to the injection port here. So I'll just wipe that, make sure that it's absolutely clean. And being very, very careful not to contaminate or to touch any of the non-sterile equipment. Going to inject the cefazolin into the burette, followed by the gentamicin. And I'll just mix that. The medication will then be instilled into the patient, and the catheter will then be clamped, and no dialysis will proceed for another 6 hours, and that will allow time for the antibiotics to be absorbed into the bloodstream from the peritoneal cavity. The antibiotics need to dwell for 6 hours minimum before recommencing peritoneal dialysis.
Once the treatment is finished, or we see some return of residual renal function, we can cap off the patient line. That's a matter of closing all clamps, remove the protective cap, and then place that on the end of the luer lock. Again, clockwise position. Make sure that you've got a tight connection. The pin and the line then goes into the povidone iodine solution for extra antimicrobial protection.
So in conclusion, we hope that this training video, the information booklet, and the peritoneal dialysis pack will give you the equipment and the knowledge in order to safely perform peritoneal dialysis. In addition, we hope that you will be able to perform the insertion safely, that you'll be able to perform the peritoneal dialysis, extracting excess fluid and electrolytes. And in addition to that, we hope that you will identify those children who've developed acute peritonitis. The packs that we have supplied will include all the necessary equipment, disposables, fluid, and documentation sheets for your use. We really do hope that you can give us as much feedback as you can on the training videos, on the booklets, and also the dialysis packs in order for us to improve the system and hopefully provide you with a better service in the future. We hope you manage to establish the service, and we hope with the assistance of this pack and this training module that you can safely perform acute peritoneal dialysis on those children with severe acute kidney injury. Thank you.